So again, challenge is identifying the parent vessel, because quite often the multiple branches of the pericallosal artery and the callosomarginal artery may mimic like a parent vessel. So we'll have to be careful to identify which is the correct parent vessel. And especially in the presence of subarachnoid hemorrhage in that area, it can get pretty difficult. So one of those opposite side pericallosal vessel was mobilized and then pushed away. And then by sharp dissection, so that's the proximal artery identification, parent vessel, and then putting a temporary clip there. And that's the dome of one side aneurysm. And you can see densely adherent vessels, branches. By gentle dissection and sharp dissection, removing it away, and we are able to see the, and we find that the clot, there was a large clot there. So we thought we will remove the clot, suck out that area so that we'll be having a better delineation of the neck of the aneurysm. So these mirror aneurysms are rare. I think in the literature, very few aneurysms have been reported bilateral, same side, I mean, same level mirror distal anterocerebral artery aneurysm. That's the clot being removed. To better delineate the neck. We also had to do a little bit of dome remodeling before applying the clip, because it was kind of difficult to maneuver the clip in that angle. And in the process, some rupture and bleeding was encountered, controlled well. We were able to clip both sides. For want of time, we'll move ahead. And that's the post-operative scan showing the two clips. And coming to the role of endovascular coiling, the technical difficulties we already told initially, and outcomes have been analyzed between systematic analytical studies for DACA aneurysms. So there are two main papers which are being analyzed. One was published in 2008 in neurosurgery, total of 501 cases. And the other one was in 2017 published in World Neurosurgery, where there were 1,329 cases of DACA aneurysms which were analyzed. We'll just go through this in a short duration so that we'll know that what are the difficulties and how to approach these aneurysms. So if we see the surgically clipped as well as the endovascular, you can see a large difference. Quite often, this is now getting skewed more towards the endovascular in all other circulation aneurysms, but in the distal anterocerebral artery aneurysm, still microsurgical techniques are the first mode of choice. And we find almost 250 cases in the first study and just 12 cases. And in the how the endovascular is still the second option only in these patients. So there are ruptured and unruptured, and the factors which have play the favorable outcomes are the age at presentation, what is the grade at presentation, and how severe was the preoperative bleed. Morbidity wise, roughly about mortality is about 5 to 6%. Morbidity is anything between 30 to 40%, again depending on the size of the clot. And surgical options tended to have lesser morbidity and lesser mortality compared to endovascular. So can it be done with excision and trapping? Yes, few case reports have been proposed where there have been large aneurysms and they have done a side-to-side anastomosis and done a bypass and then gone ahead and excised or trapped the aneurysm. I do not have experience in that. So in conclusion, complete occlusion rates are better with surgical clipping. Technical success rate were higher in the surgical group. Recurrence is less in surgical. Rebleed rates are less in the surgical group. And pre-procedure mortality and morbidity, post-procedure morbidity and mortality, intra-procedural rupture rates and long-term favorable outcomes were statistically insignificant between the endovascular or the surgical group. So the take-home message is, Dhaka aneurysms, although rare, it is a technically challenging aneurysm, but surgical clipping is the preferred modality, and you need to be very good in microsurgical techniques to give good outcomes. Endovascular coiling is a viable option in selected cases, and treatment gives significant improvement and is the only treatment should be advised for these patients. Conservative management should not be advised because almost 80% are dead in the first 1 year. Thank you.
Thank you, Professor Balamurugan. And I would like to request Professor Konokanta Burua sir to take his chair as a chairperson, as he's here. Sir, please come to the dais, sir. And
yes, please.
Very nice talk, sir. So my concern is, did you ever try Dhaka aneurysm in lateral semi-sitting position?
No.
That's what we prefer. We feel it's good for brain relaxation.
Yes, lateral, same side down, I think is a very good positioning for relaxation. But then anatomical tracing of vessels is that much more challenging. I think with a neutral position, anatomical identification and tracing of vessels is easier. And I think it's basically how you are trained. So the surgeons whom I have trained with, and now I'm doing all by myself, I feel that it is so much more easier in the neutral position rather than in the lateral position. Also, lateral position, the amount of retraction is very less. But with good anesthesia and good relaxation, I think that can be circumvented in either of these two. Proximal control, I feel, will be easier in the neutral position because you're 100% sure about the location of the parent vessel. And also the placing of the clip will be easier when we know the anatomical flow of the vessel, towards which side the flow is going to be. So it's easier to picture. I mean, this is my view. I'm sure each one of us, as we grow with each technique, will have their own views on this. But I've grown up with this, so I think it's easier for me this way.
so thank you, Professor Balamurugan. Any other questions regarding this? So now I request Professor Kusumo Noda. He will talk about surgical strategy for complex aneurysms.
Okay, so first of all, I would like to express special thanks for the professor and the staffs, all of the staffs of the conference for this invitation of this wonderful conference. Thank you. And today I will talk about the surgical strategy for complex aneurysms. So before the conference, I got a mail from the Professor Muhammad. There is he said, as per Asian regional economy, only endovascular solution for neurovascular pathology is not realistic. So it's true, I'm completely agree with this. So microsurgical management is still an effective and viable solution in this continent. So I will talk about the surgical solution for the complex aneurysms. First, I talk about the M1 complex aneurysm. This patient is 47 years old and right side huge aneurysm, M1 aneurysm. And she is very lucky because she has a very big lenticular striatal artery distal to the aneurysm. Now you can see the ICA, and here you can see the common trunk of the lenticular striatal artery. This is the key for this operation. So we made a double barrel bypass to the distal MCA and finish it. And this is the proximal contour of the M1 and the A1, and then direct puncture to the aneurysm and decompress it. So you can see the perforators just behind the aneurysms. In this situation, we can safely put the permanent clip and complete occlusion of the M1 aneurysm. And you can see the lenticular striatal artery because she has a common trunk of the lenticular striatal artery. This is the schema. The retrograde flow from the STMCA double barrel bypass went through the lenticular striatal artery. So she has no deficit and ischemic complication. And this direct suction decompression is very important technique for us to manage with this kind of giant aneurysm. And next case, this is the case. Now, this is IMPRESS operative neurosurgery. So you can see in the website, this is a M2 trunk complex aneurysm, 40 years old female, left M2 trunk large aneurysm. You can see the preoperative CTA. There is a very strong calcification and dissecting the distal transsylvian fissure and put the STMCA bypass. You can see the lenticular striatal artery arising from the aneurysm itself. So we go to occlude the aneurysm and remove the calcification part. Then we try to put the neck clipping, but it's impossible to rescue the lenticular striatal artery. So we decided to the end-to-end anastomosis in between the M1 and M2. Then here is a lenticular striatal artery. Now we made the Fishman's trimming and performing the STA lenticular striatal artery bypass to save the lenticular striatal artery area. And the ICG shows a very good flow to the lenticular striatal artery. The postoperative CTA shows also good flow in the STA, and the post-operative diffusion image shows no ischemic complication. She has no deficit and come back to home. And the next case, so I want to talk about the small perforator bypass. So next case is the subarachnoid hemorrhage case, right vertebral artery dissection. 54 years old male, heart and cosmic grade 3. So pre-operative CT showed the subarachnoid hemorrhage and the right vertebral artery dissection. So this is a transcondylar fossa approach and confirming the dissecting point already trapped. And you can see the small vessel arising from the exact rupture point. This is not the pica. This is the pica is much distal, and this is a medullary branch. You can see that this white square is the 1 millimeter. So this artery is less than 0.5 millimeter. But in the same technique, we can make the vascular reconstruction for this kind of artery. Just do the Fishman's trimming and intima to intima suturing. It's very small, but we can do the vascular reconstruction. The point is the Fishman's trimming and everting the edge of the artery. Then we can make the intima to intima suturing much easier. This is the ICG, shows very good flow to the medulla. So as you know, if you treat this kind of aneurysm dissection by the endovascular internal trapping, almost half of the patient got medullary infarction after diffusion image, after postoperative diffusion image. So this is, I think this is a very important technique to treat this kind of patient. Okay, so this picture was 5 years later, 6 years later after surgery. He has no atrophic change in the neck, and also he has no deficit, and go back to his own job. And next case, this is the high floor bypass case. The right side IC anterior wall aneurysm. The ruptured case. The patient went to another hospital. It's not our hospital, but day one DSA shows no aneurysm here. Retrospectively, there is aneurysm, and day 5, this, and day 40, the aneurysm grown up. Then he came to our hospital. So we decided to the high floor bypass and trap the ICA, try to trap the ICA, and the neckline is opening and the distal transcervical approach. As yesterday, we washed the cervical cistern and remove the clot. And at first, we make the STA-MCA bypass and the radial artery graft, and the neck is anastomosis. Then we can go to the anterior craniodectomy and open the distal dural ring. We can confirm the aneurysm itself. Fortunately, already the wall of the aneurysm is very strong, so we can put the neck clipping. And already I made the high floor bypass, so I can put the permanent clip to make the stenotic to the ICA. It's no problem because there is a high floor bypass already. So the anatomical point of the high floor bypass issue radial artery M2 bypass is, in my thinking, in my mind, so the anatomy is very important. Understand the structure of the lateral and the medial pterygoid muscle. So here is the digastric muscle. So previously we make the high floor bypass under the digastric muscle, but now we put the finger lateral to the digastric muscle and penetrate the lateral pterygoid muscle and make the high floor bypass. The anatomy of this under the jaw structure is very difficult to understand. So I made this illustration. So next case is bilateral vertebral artery dissection. I treated with the V3 radial artery P2 bypass. 48 years old male, and bilateral vertebral artery dissection. And the right side is, the shape of the right side is changing. So we try to do the high floor bypass for him. So at first I harvest the STA, and you can see that this is vertebral artery V3 segment. Then after I doing the mastoidectomy and confirming the facial nerve, and this is a semicircular canal, you can see. Then craniotomy. And I'm doing the occipital artery pica bypass, OA pica bypass at first. and go to the middle fossa and confirming a GSPN middle fossa drilling. After that, I take out the edge of the petrous bone. Then you can cut the tentrium. Under that, you can see the SCA behind the brainstem. And the SCA bypass at first. ICG shows very good flow to the SCA. And now I insert the pressure monitoring system to the STA, and now monitoring the pressure of the posterior circulation, and put the radial artery PCA bypass. And here is a vertebral artery and anastomose in the neck, backside of the neck. Then we can open it. So now the posterior circulation is completely secured. So I can confirm the perforators from the vertebral artery and trap the dissecting point. The ICG shows very good flow to the medullary branch of the vertebral artery. Postoperative CTA shows the disappearing of the bilateral dissecting aneurysm and very good flow of the high flow bypass. And the basilar trunk is got the blood flow, retrograde blood flow from the high flow bypass. So this is the schema of this operation, the V3 radial artery P2 bypass, and reconstruct the posterior circulation. And this is the patient 5 years after the surgery. Unfortunately, he has a little scar in the head. Because of his hairstyle is a problem. He always cut here, so it's appear the alopecia. But you can see there is no deformity in his head and no muscle atrophy happened. So again, I got the mail from the Professor Muhammad. So today I want to emphasize on the endovascular and the open surgery help each other and how to treat without the endovascular situation. So this is a case, this is not aneurysm, but this is a surgical embolectomy case. This is 10 years ago, we did the case, left M1 occlusion, 71 years old man, right hemiparesis. Preoperative CTA shows left M1 occlusion. He came in. This time we had no good endovascular surgeon. So preoperative MRI scans shows the M1 embolus. So we rush into the operation. So you can see the time counter here from the skin incision. After 30 minutes, we can cut the M1 and take out the embolus and suture it and recanalize it 22 minutes. And this outside, again, cut it, suture it, and open it. So 27 minutes from the skin incision, we can completely recanalize the MCA territory. So this is a postoperative diffusion image. No new infarction happened, you can see. Okay, but now the endovascular era. So we have changed our strategy for the treating the cardiogenic infarction. So we have to treat the cardiogenic infarction. First line is IV TPA, and the second line is the mechanical thrombectomy. And as a third line, as a salvage surgery, we perform the surgical embolectomy nowadays. So this is a case. This patient is 69 years old male. NHS has 30, onset to year is over 3 hours. So preoperative MRI shows already there is the diffusion high infarction. So endovascular surgeon rush into the angiography and take out the left embolus like this, but not completed, incomplete recanalization. So again, he tried to remove it, but angiography shows the extravasation. So we have to repair it. We rush into the OR and take out the clot. You can see the severe subarachnoid hemorrhage happened. So I'm very confused. So I put the wrong temporary clip this time, re-clip again and confirming the rupture point and suture it. It is very difficult because it's damaged the artery. So it is difficult, but we can repair it. Then after recanalized and the distal embolism is found it. So again, we cut it, take it, and suture it. It's very simple. Cut, take, and suture. After surgery, like this. So today my take-home message is we have to train ourselves. So young neurosurgeon, you should train the bypass anastomosis, and there must be some space we have to do. We never, the point is never give up to treat the patient. Okay, thank you.
Thank you, Professor Kosumo Noda, for your valuable speech. Now, it's open for discussion. If any query or questions regarding his speech.
Congratulations for your brilliant job. Yeah, it looks amazing to see such beautiful job you did. Congratulations. So question is, which one is this primary? Is this, if I give 10 points for your surgical skill, how much point would I give you for your sketching skill? You understand my question? Your surgical skill, if we score 10, then what is your skill for sketching? Is this 10? You are brilliant in sketching.
Yeah.
I think this skill is more than your surgical skill.
Thank you very much. I like to sketch. So in my opinion, the sketching is very good way to understand the anatomy. So I always teach the young guys to sketch before surgery and after surgery to understand the anatomy. Thank you. So.
For your arteriotomy and removal of the thrombus, what was the time frame when the patient presented to you and when you did the surgery? Removal of the thrombus at what time or what the time interval in between the presentation of the patient and your surgery?
Yeah. When I decide to do the surgery,
Timing, yeah.
Yeah. It is difficult. The therapeutic window is different in each patient. So it depends on the collateral flow. So after giving up the endovascular surgery, so there is the data. If the one pass, first pass is failed, the patient outcome is very bad in the endovascular treatment. So we always give 1 hour chance to the endovascular surgeon. If they failed within the 1 hour, recanalization, we go to the MRI scan and still there is a diffusion frame mismatch, we will go to the operation room. Okay.
Thank you.
Thank you very much.
Professor Noda.
We have parallel session in the next room, and that is the session of bypass. Can I ask Dr. Atik, Professor Dhawan Asif, and Rajkumar, and Professor Shafiul Alam to go to that room to start the session. Professor Shafiul Alam, Professor Dhawan Shamsul Alam, the Professor Dhawan Shamsul Asif, Dr. Rajkumar and Dr. Atik Rahman to go to that room and start the session, please. Dr. Mushir, please.
Next speaker will be on, I think it's online. Professor Tsuyoshi Izumo. He will talk about fundamental techniques of clipping surgery and selection method of clip type.
Tsuyoshi Izumo from Nagasaki University. I would like to express my appreciation for being given the chance to speak this time. The topic today is the fundamental techniques of cerebral aneurysm clipping surgery and selection of method of clip type.
There are many crucial steps for successful clipping surgery for cerebral aneurysm, from preoperative planning by imaging studies to cranioplasty and skin closure. Because of the time constraints, I would like to focus on these steps this time. Number 9, complete exposure of the aneurysm by detaching adhesions between aneurysm and surrounding structures. Number 10, appropriate selection of clips for each aneurysm. And number 11, precise clip application to the optimal closure line for each aneurysm. If you have this situation, clip application to the neck of the aneurysm is a straightforward procedure, but it is supposed to be a rare case. Dome of cranial aneurysm adhere to the surrounding structures, including dura mater, cranial nerves, and normal vessels, especially in large or giant aneurysm. For appropriate clip application and avoiding branch stenosis or nerve dysfunction by tension, these adhesions should be detached in many cases if possible. Professor Hadeishi reported how to detach the fibrous adhesion. They are consist of 3 steps. First, dissect the loose adhesion in the center using Juror's forceps to make space. Second, pinch the tight adhesion at the margin of emboss, the fibrous adhesion. Finally, sharply inside the embossed adhesion with micro scissors. Detaching the adhesion between nerve and aneurysm is also possible by this technique. I will share with you the techniques using my video afterwards. Each aneurysm has an orifice from its parent artery. Clipping of aneurysm is aimed to obliterating the 3-dimensional orifice of the aneurysm and recreating the curved or straight line with the base of the aneurysm clip. We call the line ideal or optimal closure line. Professor Ishikawa classified the ideal closure line of MCA aneurysm into 3 groups: the bifurcation type, the truncal type, and the combined type. The bifurcation type is the most common type in MCA aneurysm. This type originated from the curved linear cleft at the bifurcation of the arteries, with an orifice forming a deeply curved rhombus. In this case, we should apply aneurysm clips in perpendicular fashion to the arteries. Of course, one clip is enough in some cases. The second type is truncal type. This type appears to originate from loss of tunica elastica on one of the afferent arteries, with an orifice forming the flat rhombus on the parent artery. In this case, we should apply aneurysm clip in parallel fashion to the arteries. Of course, one clip is enough in many cases. The third type is the combined type. In this type, the growth of the aneurysm destroys the tunica elastica of the continuous vessels with a subsequent enlargement, with an orifice forming a curved trapezoid. In this case, we should apply clips in cross fashion. We must know the aneurysm clipping closing forces. The most important component of aneurysm clip selection is subjective preference, though objective decisions based on the closing force may be relevant. Professor Hongo reported the closing forces of all of tested clips linearly increased from tip to base of the clip brace. So you should know that an incomplete closure of the far side neck would happen when you use a long clip for a large aneurysm. And you should know not straight clips are weaker than straight clips. We must know those characteristics of each clips and use appropriately considering the closing forces. Clipping for recurrent aneurysm after initial endovascular coil embolization is technically challenging. Dissecting and clipping of small aneurysm with sufficiently large neck remnant is a straightforward procedure. On the other hand, in larger aneurysm, the fundus is thrombosed and mechanically enforced by the coil mass and sclerotic wall, rendering manipulation and exploration more difficult. Like case above, despite angiographically sizable neck remnants, collapsing the aneurysm wall at the neck and clip application can be very difficult. Previously coiled aneurysms are difficult to clip, partly because coil loops and mass inside can prevent the clip brace from complete closing. There must be a residual flow in the aneurysm after a single clip is applied because of inadequate closure of the far side neck by the obstacles. Hence, a tandem clipping method using a fenestrated clip in combination with another type of clips is a useful technique for complete closure. The former can be applied for closure of the far side neck, the latter for the near side. When you apply an aneurysm clip to the neck, you should make a fine adjustment for appropriate application to its optimal closure line. Professor Takanori Fukushima introduced the 5D application technique of the aneurysm clip for me. In this case, D does not mean dimension, but direction. First, you go with clip in and out. Second, left and right. Third, up and down, including blade tip up and blade tip down. And clockwise and counterclockwise rotation around the clip axis.
Hello everyone, my name is ZooM from Nagasaki University. I would like to express my appreciation for being given the chance to speak this time. The topic today is the fundamental techniques of cerebral aneurysm creeping surgery and selection and method of creep type.
There are many crucial steps for successful creeping surgery for cerebral aneurysm, from preoperative planning by imaging studies to cranioplasty and skin closure. Because of the time constraints, I would like to focus on these steps this time. Number 9, complete.
So, thank you, Professor Suyushu Izumo. And our next speaker will be online, Professor Koichi Arimura. He will talk about the echomaneurism.
Okay, thank you for the chance of speaking in this conference. And could you start my recorded video presentation?
Hello, Professor
Hello,
Koichi Arimura.
I have sent the recorded presentation video. Do you have a video file? Can you hear me?
Yes, we can hear you.
I have sent the pre-recorded video presentation for you.
I think it will be there.
Or can I share the presentation video in this Zoom meeting? I cannot share.
Yes, yes, you can share the audiovisual speech.
No, I can not share the files in this meeting.
They're trying to
Because I am trying to share the file, but it is denied. I pushed the button to share the video, but
it
is denied.
Trying to share it. Please wait. They are sharing.
Yes, it is. So please start the video.
It is a great honor for me to have an opportunity to speak in first ACNS BSNS hybrid conference and workshop. My name is Koichi Arimura from Kyushu University. Today, I'd like to talk about the basic strategies and techniques of clipping surgery for anterior communicating artery aneurysms.
So Professor Arimura, you can start.
Yes, you have already studied the presentation video.
Cerebrovascular diseases such as direct
You can see
vascular treatment and hybrid approach. Today, I'd like to talk about the basic strategies and tips of the clipping surgery echo aneurysm. We have two major approaches for the clipping of echo aneurysms, such as terminal approach and interhemispheric approach. It is very important to choose the better approach to make the clip
I like to crest handover ceremony will be given by
Please step away. Oh. Please. Yes. আচ্ছা আচ্ছা একজন করে দাও সকলে সুমিতা কি যাও
Professor Taksumi Takijawa.
Let me hand it to you. So,
Now, Professor Balamuga.
Thank you.
Thank you, sir.
Yeah, please.
Professor Kusumu Noda. Thank you.
Dr. Suzuki. Please.
Professor Suzuki. Come here. Thank you, everyone.
Thank you very much. We'll take a break for 15 minutes, then we'll come back. We will take a break for 15 minutes, then we'll come back for the last session. Thank you. Come back to the first session.
Yes.
First with our next.
Can I control my presentation? Hello. No, I know. I only want to confirm. I only want to check. Okay. Straight transmural sulcus approach to deep sea. Not about vascular search. Yes, endovascular. Yes,
So I welcome you all to today's our last session, I think so, session 9, aneurysm session C. Today we have chairperson Professor Kosumo Noda, then Professor Bala Murugan, sir is here. Then Professor Shafiul Alam and myself, Colonel Salek. So we have a bunch of experienced speakers here. Then Professor Abujar Gunjar, Professor Susumu Yamaguchi, Professor Sutomo Aishinos, Professor Katsumi Takizawa, and Professor Sachin. First of all, I welcome to the first talk which will be delivered by Professor Abujar on interhemispheric transcingulate sulcus approach to deep-seated lesions. Please start.
Again, I want to thank all organizing committee. And today we might be bored with vascular surgery. My presentation will be about. Okay. My presentation will be about two new approaches, and I will show some 5 white matter dissections from our laboratory. And again, I want to thank all countries who help us in our disaster earthquake last month, from Japanese in India and from Bangladesh. All teams came and helped us. I have no conflict in interest, but I have a big team behind me. As you know, there's extended white matter anatomy under the cortex. And for example, this is an arterial tumor. I want to talk about another approach we described recently. For these arterial tumors, you can use a lateral or superior or medial approach. But as you see, all approach, even 1 watt-meter thorax will be damaged. And we try to describe a less invasive technique, and we try to describe the parieto-occipital fissure to approach the atrial tumors, because if you use these sulcus, you only damage a small portion of the callosal fibers and reach atrium. As you see, this is a small part of cortex, which and only some part of callosal fibers. As you see, when you use parieto-occipital fissure, you can reach atrium. And this is the steps of our surgery. First, to describe the parieto-occipital fissure and its relation with the atrium, and removal of the tumor and the lesions. And this is the postoperative view. You can see the parieto-occipital fissure and minimal damage of the callosal fibers with preserving the optic wave pathways and other watt-meter thorax. You can find detailed information from our article. And there are more challenging cases like this, because you can see this is the cortical spinal tract and the motor area. And we want to solve this problem. As you see, you can see the homunculus, but the homunculus finished the cingulate sulcus. And then we think if we can use the cingulate sulcus like we did in parieto-occipital fissure, and we dissected, this is a cingulum and callosal fibers. Only damaging small cingulum and callosal fibers, we can reach the deep frontal and parietal lesions. Yes, I know it is difficult, but we did in the previous study like that with using the gravity and dissection, you can reach the this area. As you see, this is the position which I used in our operation, in thermospheric operation, to use gravity without retraction. And as you see, they describe the cingulate sulcus. And this is the steps of the surgery, dissecting the bridging veins and finding the cingulate sulcus and dissecting and removal the lesions. And this is the postoperative view. You can see without damaging any structures, you can remove this kind of lesions. As you see, we can use the cingulate sulcus without damaging any cortical and watt-meter thorax. This is a surgical video of my case. This is a child. Also, he had multiple surgeries because of the multiple cavernomas. I'm side down position and open the burr holes above the sagittal sinus. And firstly, dissecting the bridging veins and try to open a cingulate interhemispheric fissure. After opening the interhemispheric fissure, I control to the lesion with ultrasound, and then the superior sagittal sinus. And after control with ultrasound, we describe the cingulate sulcus. And after seeing the corpus callosum, you can describe the cingulate sulcus, because cingulate sulcus just located the corpus callosum, first sulcus above the first corpus callosum, and start dissecting the sulcus without damaging any vascular structures. Also, you can use navigation to navigate the tumor. As you see, it is a deep sulcus, and you can dissect along the all sulcus. And after finishing the dissection of the singular sulcus, we can reach the lesions, tumor or carcinoma. This is a carcinoma case. As you see, after dissecting and looking for the residual carcinomas. And you can see removal of the carcinoma. And you can see the postoperative view of this case. Only some cortical tissue just under the singular sulcus, we can remove the this carcinoma. And this is the postoperative view of the patients. And also you can use these gliomas and the like this in this case. And you can find the videos and all data in this article. It is published in Operative Neurosurgery. And also you can find all our white matter dissection 3D models in Neurosurgical Atlas. We are cooperation with Neurosurgical Atlas, and our fellows job is published with Aaron Gadol, and you can find these models in Neurosurgical Atlas. And this is our laboratory. Whenever you want, you can come and visit us. And also we accept a fellowship from international fellowship for 1 year. This is the 3D model of our laboratory. We have workstations and a microscope. And I want to thank my fellows and Rashagil and Urture and Roton. Thanks for your attention.
Thanks, Prof. Abujar, who has nicely shown the deep-seated lesion by interface break, transnuclear sulcus. I just forgot that he has expressed his deep thanks and gratitude the international team who helped them during their disaster management last month. Luckily, though I was not the member, but I was selected to be there from the army. But my colleague went there, and they have come back safely by doing their tasks as a rescue team. So we pray for your nation and to rebuild again. Thank you. So now the second topic is MC aneurysm. That will be delivered by Professor Susumu Yamaguchi. He's online, huh? Okay.
Online.
He's online, huh?
Online.
Online. Professor Susumu Yamagasi, he will deliver his lecture or talk on air.
I am requesting Professor Ashit Chandra sir and Professor Numan Khaled sir to come in the dais.
Okay, with some technical difficulty, we are going for the next one. The posterior circulation aneurysms by Professor Sutomo Isinos. Is here?
Yes, I'm here. Can you hear me? Okay. Can you hear me? Okay. Thank you for your invitation. I'm glad to join this conference. Now, I want to start the video, but I cannot. The host don't permit my starting my video.
Can you start video?
Hello, can you hear us?
Yes.
Yes, yeah, you are also.
Yes, this is
Please
Tom
proceed.
Ichinose from Osaka. I cannot start my video because the host don't permit my starting the video. Okay.
Please start the video, please.
No. The host don't permit the.
Please permit him to share the screen.
Yeah. Yes. No. This is a
pleasure to be with you today. My name is Susumu Yamaguchi from Department of Neurosurgery, Nagasaki University, Nagasaki, Japan. I would like to present the basic technique of microsurgical clipping of MCA aneurysms. Recently, as endovascular treatment has developed, the number of clippings is decreasing. However, MCA aneurysm has features of complicated shape and relatively easiness concerning approach. Therefore, I expect that many clipping procedures for MCA aneurysms will still be performed in many institutions. Today, I will talk about these issues. In clipping for MCA aneurysms, the exposure of M1 is very important. Therefore, operators should estimate the location of M1 in preoperative planning. In upward type, M1 is found caudal to bifurcation like this schema. On the other hand, in downward type, M1 is found cranial to bifurcation like this schema. Sometimes we face short M1 or early bifurcation. Early bifurcation or short M1 is defined if the length of M1 is less than 15 millimeters. In this case, many LSA arise from post-bifurcation branches. Therefore, these LSA prevent safe neck clipping. In addition, the aneurysm is located deeper in sylvian fissure, wide opening of cerebral fissure is required. This is a case of short M1. Preoperative CT angiography showed the length of M1 was 10 millimeter. LSA are running through the aneurysmal neck and dome. In this case, we are afraid of LSA injury and spasm caused by complete dissection of LSA from aneurysm. We just dissected around aneurysmal neck and applied clip. During dissection, we found M1 perforator behind the M2. In clipping, we are careful not to clip the perforator with aneurysm. After applying first clip, we additionally applied second clip for dark ear-like aneurysmal nerve nut. Concerning head rotation, we refer to the angle of cerebral fissure. In our method, we retract only the frontal lobe with a retractor when we open the cerebral fissure. Therefore, we choose the angle in which the temporal lobe does not overlay the cerebral fissure. We often rotate the head by about 20 degrees opposite to operation site. If the angle of head rotation is more than that of the cerebral fissure, especially the angle of the wall of temporal lobe, the plane of dissection is not vertical and temporal lobe shades the space of cerebral fissure. In these cases, retraction of temporal lobe is required to open the cerebral fissure. However, this issue depends on operator's preference. The number of superficial cerebral veins are reported to be from 0 to 4. Injury to the superficial cerebral veins has a risk of venous infarction of the frontal, temporal, and parietal lobe. This is one of the examples. As the image shows, even if one of the superficial cerebral vein runs on top of the temporal lobe, sometimes the veins running on the top of the frontal lobe drain into this vein. Therefore, dissection of the vein from the temporal lobe allows the cerebral fissure to be properly opened. The insular vein can be injured when clipping or MCA bifurcation aneurysm. Recently, the function of insular cortex has become apparent, and injury to the insular vein has a risk of speech impairment and cognitive dysfunction. Sometimes the insular vein runs behind the aneurysm. Therefore, be careful not to clip the insular vein with the aneurysm. There are 4 membranes which we must cut in order to expose the MCA aneurysm located at the MCA bifurcation. The superficial cerebral vein is located between the outer arachnoid membrane and the lateral cerebral membrane. When we cut the outer arachnoid membrane adjacent to superficial cerebral vein, we must dissect the outer arachnoid membrane from the lateral cerebral membrane, followed by cutting the outer arachnoid membrane. Because if we cut the outer arachnoid membrane and lateral cerebral membrane adjacent to the superficial cerebral vein together, there are a risk of injury to the superficial cerebral vein or its branches. Once the intermediate cerebral membrane is cut, we can see M2. Sometimes there are some cases with tight space between the frontal lobe and temporal lobe. In those cases, counter pressure by suction is important. Adequate counter pressure makes it easy to identify the dissection plane. The compression site is better when it is close to the dissection site. I use a dissector to make space where I can insert the scissor blade, and then I cut the trabecula with a micro scissor. Please be careful if you use blunt dissection because it is easy to cause severe hemorrhage or tissue damage. In the case of clipping for ruptured MCA aneurysm, frequent lavage of the clot in the cerebral fissure is important. First, making the space around M1 to insert the temporary clip in case of rebleeding is important after opening the cerebral fissure. Next, after M2 and perforator are confirmed, dissection around aneurysmal neck should be performed. Once enough space to insert the clip blade around the aneurysmal neck was obtained, neck clipping or dome clipping was applied with or without temporary clipping. No filling was confirmed by ICG video angiography and or Doppler. Then whole aneurysm should be exposed, and then no involvement of any earth vessel and adequate placement of clip should be confirmed. This is a case where rebleeding occurred just after cutting the dural matter. First, a temporary clip should be applied via the subfrontal approach. Next, the temporary clip should be applied to the M1 origin. The assistant operator should perform pinpoint suction of the bleeding point. During the suction of bleeding by the assistant operator, the operator should dissect around the aneurysmal dome. Once the operator applies the temporary clip for the aneurysmal dome, the temporary clip located at M1 should be removed. In order to complete the neck clipping, the operator should dissect the aneurysmal neck. After applying temporary clips for M1 and the M2s, the temporary clip applied to the aneurysmal dome should be removed. Then neck clipping is performed. After neck clipping, all temporary clips are removed. In order to confirm the complete clipping and no involvement of important vessels, the operator should observe the back of the aneurysmal dome and neck. In this case, an additional clip was applied to the residual aneurysm. In the case of clipping for unruptured MCA aneurysm, first, after opening the cerebral fissure, it is important to create space around M1 to insert the temporary clip in case of bleeding. Next, after M2 and perforator are confirmed, this section around the aneurysmal neck and dome should be performed. After the whole aneurysm is exposed, neck clipping is performed. This case is unruptured MCA aneurysm coexisted with convexity meningioma. Due to tumor, right M1 was elevated. After tumor resection, we performed clipping. This aneurysm neck involved more than 180 degrees of the parent artery. Therefore, we performed complex clipping using 2 clips. First, we applied a straight clip to the aneurysmal neck, but this has a risk of creating a stenosis at the bifurcation because the artery and aneurysm showed atherosclerosis. Therefore, we applied a second clip parallel to first clip, and then we removed first clip. Next, we applied an additional clip to occlude the bleb close to aneurysmal neck using a fenestration type clip. In conclusion, visualization using preoperative CT angiography or MR angiography is important. Adequate counter pressure using a retractor is helpful for opening the sylvian fissure by sharp dissection technique. In some cases, the shape of aneurysm is complicated, therefore, several clips are required for complete occlusion. Thank you.
Thank you, Prof. Susumu. Now we'll go for our next talk that will be delivered by Professor Shutumo. Okay, before that, for the audience, do you have any question regarding the MC aneurysm? Or any comment, valuable comment? Okay, thank you. Now we'll proceed our next talk on posterior circulation aneurysms by Professor Sutumo.
Excuse me. Can you change the setting of the this Zoom? I cannot share my video clip on the Zoom.
Okay, please help him to share the screen.
I cannot share because the host doesn't permit my sharing the my video clip. So please change the setting of the sharing permission.
Okay, we are making you admin, so we'll be able to share your screen.
Yeah. Okay. Thank you for it. Permission, and I will start my presentation video. Can you see my video? Okay.
We can see, yes.
Yep.
Hello. Yeah, there is can you unmute him?
一之先生、音が共有されてないみたいで。今、音声が。
OK です。ちょっと待ってください。
The skill and mind of life surgery should be preserved. There are several surgical approaches to the distal vaginal aneurysm. Temporal, zygomatic, or zygomatic infratemporal, zygomatic temporal, transcavernous transfer, extradural temporal, and pretemporal. The anterotemporal approach is very good for vaginal tip aneurysm. Dr. Allen and Professor Cato reported in the literature. Anal clipping remains as the immediately available option in countries without facilities for coiling. The scale will need to be continually preserved. I will show the several illustrated cases. Case 1. 84-year-old female. She presented with a subarachnoid hemorrhage, double FNS grade 4. We can see the diffuse subarachnoid hemorrhage with mild hydrocephalus. The 3D CT angiography shows the 3 aneurysms. The vaginal tip aneurysm is the largest one and it has 2 brevus. There are 2 small aneurysms in the right ICA and left SCA. At first we tried the coil embolization, but the access route was bad for the catheter. The catheter cannot be stabilized, so the coil embolization was failed. Left side is coronary image and right side is sagittal image. The tip of the aneurysm is very high from the posterior crinoid process. So I chose the right orbit diagnostic osteotomy. I will show the operative video. Now I perform the craniotomy to expose the frontal lobe and temporal lobe enough. At first, I open the Schleiden fissure from the distal side to the proximal side, and open the lamina terminus and extract the brain, and dissect around the cerebral veins, and M1 and A1, and retract the frontal and temporal lobe enough. We can see the anterior crinodectomy to mobilize the ICA to the medial side and remove the anterocrinal process and open the dural ring and approach from the lateral side of the carotid artery to the posterior fossa. Now I dissect around the both P1 and place the temporal clip to the vaginal artery and dissect around the annular neck and apply the fast grip to the vaginal tip aneurysm. I confirm the preserve of the perforators and then I crept to the small aneurysm on the left SCA, and the underside of aneurysm was completely crept by small crepe. And this is the final view. This is the post-operative image. The patient recovered well, and the 3D CT image shows the all aneurysms are nicely crept. Case 2. 72-year-old female, the Baja SCA growing aneurysm. At first, this aneurysm was 5 mm but growing to the 10 mm. The PC and the SCA was branching from the aneurysm dome, so we selected the direct treatment. Left side as coronary image and right side as sagittal image. The aneurysm and the branching point of PCA is relatively high, so we selected the zygomatic osteotomy from right side. This is a perioperative simulation image. Left is anterotemporal approach and right side is subtemporal approach. We can easily understand anterotemporal approach can provide a wide surgical corridor. I will show you the operative video. The patient was placed in the supine position and head was rotated to the contralateral side. We prepared the transcortical MEP monitoring, and this is a monitor of the MEP. We cut the half colon skin incision and made a dissection interfascially the temporal fascia and refract the temporal muscle inflatorily. And then we cut the zygomatic arch and the outer limb of the orbit, and they cut and reflect the temporal muscle inferiorly. We designed the craniotomy line and the ciliary fissure and made the craniotomy and drew out the sphinal ridge and cut the door circumferentially and refract it. We open the ciliary fissure from the distal side. The subarachnoid dissection was completely performed. While preserving the tiny vessels, and we can see the sun nerve and the SCAs and the retracted temporal lobe maximally, and we can see the whole course of the oculomotor nerve, and we approach to the Badger artery, but the sun nerve was attached to the proximal control. So we open the pores of oculomotor layers and perform the temporal creep to the Badger artery, and then apply the creep to the neck of the aneurysm, was preserving the all normal structures. The post-operative images. The patient shows a transient oculomotor palsy, but It recovered completely within the 2 weeks. There are no apparent ischemic and hemorrhagic complications, and 3D CT angiography shows good creeping. The case 3, 74-year-old female. She had a Badger SCA growing and thrombosed large aneurysm. It led to the left hemoparalysis by compressing the brainstem severely. The T2 weighted image shows the large aneurysm severely compressing the brainstem, and center panel is the actual image of enhanced CT scan. The neck itself is relatively narrow, so maybe we can perform the direct clipping to the neck. Left side is a coronary image and right side is sagittal image. The tip of aneurysm and the branching point of PCA is relatively high, so we made the anterotemporal craniotomy with zygomatic osteotomy. This is a perioperative simulation image. Left side is zygomatic osteotomy and anterotemporal approach. Right side usual terminal approach. This patient has a past history of ICPC aneurysm creeping, so we needed more wide and lateral surgical corridor by anterotemporal approach. I will show the operative video. We already performed the craniotomy and zygomatic osteotomy, and temporal lobe was retracted maximally. And we can see the previous clip of ICPC aneurysm, but we can approach from more lateral side by anterotemporal approach. The oculomotor nerve interfered the approach to the proximal side of Badger artery, so we open the oculomotor system. And as the preoperative simulation image, we could approach the distal Badger artery node structures. We can see the contralateral oculomotor and the SCA. And finally, we could apply the aneurysm grip to the neck. We can see the contralateral side, and this is the final view, and confirm that all the best is preserved by the ICZ. This is a post-operative CT scan. The left hand paralysis and transient oculomotor palsy recovers completely. The post-operative image shows small neck remnant, but there is no apparent leg loss. The upper side is a perioperative MRI. The brainstem was severely compressed. 3 years later, the aneurysm shrinked and the patient is good condition. There are several factors for approach to the distal Badger artery aneurysms. According to the size and height of aneurysm, zygomatic osteotomy and posterior craniotomy is needed. According to the length and angle of ICA, we need an anterocraniotomy. If the surgical corridor is interfered by oculomotor nerve, the opening porous oculomotor is useful. The anterotemporal approach with adjunctive skull-base technique provides safe gripping. In conclusion, The basic and most important technique is secure craniotomy and subarachnoid dissection, even for the posterior circulation aneurysms. Adjunctive scalpel technique provides safe clipping to preserve normal structures. Thank you for your attention.
Thank you, Professor Sutomo. We have enjoyed your beautiful cases and your beautiful lecture. So now I will request the learned audience regarding any query or any comment, please.
Thank you, sir, for your nice presentation. I have one question. When we have to drill the posterior clinoid process, and what is the risk of drilling of PCP? Do you hear me?
So you mean that for the drilling of the posterior clinoid process?
Yeah.
Yeah. Yes. Sometimes we need a drilling of the posterior clinoid process because the aneurysm is low position. Maybe we need to care for the bleeding from the posterior cavernous sinus, and of course we need a wide surgical corridor before the drilling of the posterior clinoid process. And opening the porous oculomotor and transpose the oculomotor nerve is also you make a wide surgical corridor. Okay.
Okay. Thank you, sir.
Yep.
聞こえますか？
はい、大丈夫です。Thank you.
I am Kosumonoda from Teishikai Hospital, Japan.
Yeah.
Thank you for your beautiful videos. And I have a comment and a question.
Yep.
So the last case, the very big basilar top aneurysm, it looks like the posterior projection and the surgical corridor is still very small. So the question is the posterior clinoidectomy. In my opinion, I don't like the posterior clinoidectomy in this case. I think the transcavernous approach behind the oculomotor nerve, and we can see the more proximal basilar trunk. We can put the basilar trunk there. The surgical corridor is much bigger for the basilar top aneurysm. Then we can dissect the behind the aneurysm. So this is my opinion. So what do you think about the transcavernous approach for this kind of aneurysm?
Yeah, thank you for your comment and help for my video presentation. Yes, I know your technique for the basilar top aneurysm, and the transcavernous approach is very beautiful. And yes, maybe it is very useful for the low set of the basilar top aneurysm. So maybe if the aneurysm is more lower part, I will use the transcavernous approach. Thank you very much.
Okay, Professor Sutomo. We know the posterior circulation have a greater tendency than rupture than anterior circulation. And now this era is the debate there, endovascular or surgical approach. Which one is superior in your opinion and from your experience?
You mean which is the superior surgical clipping or coiling? Okay. My opinion, of course, the usual case of the posterior circulation aneurysm should be treated by the endovascular approach. Is very surgical approach is dangerous, and of course we have some experience of the complication. So, endovascular is the first choice for the posterior circulation. And but sometimes in the presentation, like in the presentation, we met a difficult case by the endovascular. In such a case, we should treat direct clipping. So we should, my opinion is that we should continue and maintain the skill and mind of the surgical clipping for the posterior circulation. Maybe it's the same as a Teishinka hospital.
Okay, good. Thank you very much. So regarding the continuation of this question, the next topic is coming as surgical treatment of cerebral aneurysm in the endovascular era. And Professor Katsumi will deliver his lecture on this, please.
Hello, everyone. Today, my topic is surgical treatment of cerebral aneurysm in endovascular area. Okay. As you know, endovascular treatment developing day by day. Most important topic is GDC coil invention 1991 and the result of ISAT trial 2002. Nowadays, the first line treatment of cerebral aneurysm is changing to the endovascular treatment. But the advantage of the endovascular treatment, everyone say less invasive compared to direct surgery. It's almost correct, but I don't completely agree. I'm not. I think the endovascular treatment is not so less invasive. Also, endovascular treatment is curability is low compared to direct surgery. Recurrent rate is high. Also, sometimes need antiplatelet agent, single or double, in asymptomatic patient. Also, this treatment is very high cost. We need a high cutting edge high equipment or device is very expensive. So for example, IC cavernous aneurysm is a good indication for flow divert stent. But my question is, all case is okay in flow divert stent. This is a review articles of flow divert treatment. Complete orbitration rate is around 95. Okay, not complete. Also, there is a risk of mortality. Okay, some patient is die because of the complications. Okay, this is our case is left side symptomatic cavernous giant aneurysms. This case we decide to treat endovascular treatment for divert stent in general anesthesia and flow divert stent and coil embolizations. But this, you can see this ICA is very courteous. Also, this aneurysm is very big. So in the treatment, it will be difficult to induce the pipeline, get this corner. And so it will finally penetrate a guide wire. So occurs CCF. The surgeon tried to sinus packing, but she can't occlude the perforator point. So he said, finally, treat to this situation, we should occlude the ICA. So I decided to perform the surgery. Okay, high flow bypass and the trappings. Okay, high flow bypass is important, is not anastomosis. Many important tips. Okay. I use a radial artery and the submandibular root. Okay. This root is a blind part. Okay, so we should take care of the kinking or twisting of the radial arteries. It's the most important things. Okay. After bypass, confirm the good patency using the IC video angiogram, then occur to the proximal ICA. If the unruptured cases, it is okay, just proximal occlusion. But these cases, we should perform the trapping of the ICA. Now you can see the optic nerve and ophthalmic artery. Distal part blocks just proximal to the branching of the ophthalmic arteries. Okay, this is the final view. Unfortunately, this patient is no complication. She can return to the normal life. Okay, so for the flow diverter stenting, the giant size or tortuous ICA case is not easy. Okay, high risk for the flow diverter stent. But this is my largest cases, around 7 centimeter cases. Okay, but we can treat just high flow bypass and proximal ICA occlusion. Okay, for the direct surgery is the aneurysm size or running course with ICA is no need the risks. Okay, does not affect the surgical risk in direct surgeries. Okay. In direct surgery, we can perform the microscope and limited micro instrument and anastomosis skill, just enough. Okay. Not so expensive. So my opinions, we should select the most adequate strategy, case by cases, not only flow diverters for the IC cavernous giant aneurysm. Okay, next is how do you treat MC aneurysm? Okay, recently there are new device for bifurcational aneurysms. So endovascular surgeon said we can treat MC aneurysm also in endovascular treatment, but I don't think so. Still, direct surgery is more safely and completely. But also such a large cases is we need a bypass surgery. Okay, Dr. Noda shows videos. Commonly, this type of aneurysm, we treated double STMC bypass distal M2 and trapping the aneurysm. Okay, but this strategy is a risk of the occlusion of the proximal part. Okay, so make a stump is a risk of the ischemic complications. Okay, so recently I changed the surgical strategy, such type of MC aneurysms. Okay, this case is a ruptured right side middle cerebral artery, a large size aneurysm. Okay, this is a surgical video. Make a right frontal craniotomy, open dura. Split the Sylvian fissure from the distal side, irrigating the subarachnoid clot. Okay, now you can see the inferior trunk of the M2, aneurysm dome. And this is the superior trunk. And this is the inferior trunk M2. But we can't see the M1 because the aneurysm is too big. Okay, so firstly, I performed the STA superior trunk M2 anastomosis. Then block the proximal M2 and confirm the patency. Previously, nextly I performed another SMC anastomosis to the inferior trunk. Okay. But in this case, put the clips onto the superior trunk and cut the superior trunk first. Okay. In this situation, this aneurysm changed to the sideward type aneurysm. Okay, only one branch, the distal part of the aneurysm. So easy to move the aneurysm domes. We can confirm the M1 easily. Okay, now block the M1 and M2. Okay, so in this case, direct suction decompression is useful, but usually we should direct puncture. Okay, but I use office of the superior trunk. Suck the blood inside the aneurysm, then block. Okay, this fashion we can repeat it. Suction decompressions. Then dissect the aneurysm, and finally clips, aneurysm clips, reconstruction clips, preserving the anterograde flows. Okay, this is a post-operative diffusion image. This is a post-operative 3D angiogram. Okay, this is a schematic drawing of the surgical strategies. Okay, firstly perform the STMCA only single, then cut this M2 and use this point for the suction decompression. Then perform the reconstructing clippings, preserving the anterograde flow. Okay, this is a low risk of the postoperative ischemic complications. Okay, also after just bypass and block the one single M2, then move to the endovascular treatment. Okay, using a stent or a flow diverter is the next option. Okay. Next case is a ruptured left vaginal SCA large size aneurysm. Okay, this aneurysm is difficult to treat. Only direct surgery or only endovascular surgeries. Okay, so this case, firstly perform the OA. In this case, the ST is not so good. So we use OA for the donor artery and perform the OA SCA anastomosis. Okay, using combined petrosal approach, cut the middle fossa dura, and cut this is a tentative edge. You can see the fourth nerves and the SCA here. Okay, this is not SCA, OA. Okay, we can harvest OA along 15 centimeter. If dissect until to the distal part. Then make a bypass. Confirm the graft patency using ICG video angiograms. You can see good patency. Okay, then block the proximal part of SCA. Okay, just to finish the direct surgical part. Okay, then this is the postoperative angiogram. You can see the good patency of the bypass. Then move to the endovascular treatment. Okay, now no branch from the aneurysm domes. Okay, so endovascular surgeon can occlude it by coiling. this is just after the endovascular treatment. Okay, no ischemic complications. Okay. In conclusion, the direct surgery remains an important option for treating complex cerebral aneurysm in endovascular area. A bypass technique is essential to treat completely and safely by direct surgery. Also, hybrid treatment cannot only direct surgery or not only endovascular treatment. Hybrid treatment of endovascular and direct surgery is a useful option for treating complex cerebral aneurysm. Okay, thank you for your attention.
Thank you. Thank you very much, Professor Katsumi. So this he has nicely showed us the mandatory room for surgical option in the endovascular era. So for the learned audience, is there any comment or question regarding this talk? Please.
Can I ask? Yes. So thank you for the beautiful videos. Thank you for the beautiful video. I learned a lot. I have very similar concept for the giant MC aneurysm. So I called it modified trapping. It's not a trapping, but a modified. So it makes the not the bifurcation type. So my question is I think I cannot see exactly, but I think you cut it the anterior trunk of the MCA. So our experience, so the anterior trunk and the posterior trunk, the anterior, there are lots of lenticular striated artery possibility in the anterior trunk side, more than posterior trunk. So you cut the anterior trunk intentionally or something. Is there a reason for the cutting the anterior trunk? Why not the posterior trunk?
Oh, just this case is for select anterior trunk, not every case. It's a choice, case by case.
Okay, depends on the lenticular striate.
Yeah.
Okay, thank you. Thank you very much.
Okay, any question? Thank you. Thank you. So now we'll proceed our next and final talk, today's final talk on current state of flow diverter that will be delivered by Dr. Sachin.
Okay, so thank you very much, everyone, especially Dr. Shafiqul for inviting and arranging such a fantastic conference. And as he said in the morning, that this conference is hybrid in two terms, in terms of technology that we're doing in person and virtual, and it is hybrid in terms of the way we treat the vascular cases in this subcontinent, the India, Bangladesh, Pakistan. So the momentum is slowly changing towards the, one sec. Yeah, the momentum is slowly changing towards the endovascular, which is almost endovascular in the Western world. So we are developing countries and we are slowly gearing up with the endovascular treatment. So all my previous talks were about the surgical treatment, surgical management of the aneurysms, and Professor Takizawa has taken it to the next level, that how to manage this aneurysm in an endovascular era. And now here I am standing with the endovascular era. So big responsibility on my shoulder, but I am still beginner endovascular surgeon. I'm actually a hybrid neurosurgeon. I started with microvascular treatment of aneurysm with Professor Balamurugan in Apollo Hospital, and then I moved into my personal practice, wherein whenever I wanted to get a DSA done for the aneurysm, I refer it to my endovascular colleague. In our subcontinent, obviously, it is done by multiple people. Most of them, it is done by endovascular radiologist. And whenever I used to refer those patients to the endovascular radiologist, those patients never used to come back. So I definitely thought a desire to learn the endovascular. So I learned my endovascular neurosurgery in Nagoya with under guidance of Professor Yoko Kato. So there are three aspects which I'm going to talk about today is what is computational flow dynamic. It's a new tool, especially for the management of aneurysms. What is fundamental to applications of CFD and flow diverter. Next thing will be a parade of all the cases which I've seen with Dr. Balamurugan and some of my cases. So retrospective analysis of the radiological clinical comparison of flow diverter versus stunt assisted coiling, because slowly the dynamics is changing, the momentum is changing from the stunt assisted coiling towards the flow diverter. And there are many new flow diverters like web devices are coming. And lastly, the recurrence of aneurysm post endovascular coiling. If you do endovascular treatment and there is a recurrence, then what do you do? Which is the current my research topic. So what is CFD, computational flow dynamics? So let me explain this. Computational flow dynamics is nothing but everything which is moving. A computer can put it in a dynamic fashion and create a flow dynamic of this. So in the brain, the blood vessels are carrying the blood is moving. So computational flow dynamic with the help of 3D images, put them together and gives us information about the flow pattern of the blood, how it is flowing. Is it in the streamlined fashion, in the laminar fashion, or in turbulent fashion? And does that really have any impact on the anatomy or on the growth of the aneurysm? And what kind of device we should use, stunt assisted coiling or a flow diverter? And what kind of pressure it is causing on the blood vessel, whether it is causing any thinning of the blood vessel, because many times when you must have seen the aneurysm, like you can see this aneurysm here, some part of the aneurysm is very thick, and it is thick because of what all we know, because of the atherosclerotic plaque, but some part of the aneurysm will be very thin, and that is the part which is mostly responsible for the rupture of the aneurysm. And why is it thin? Because if we assess it in a computational flow dynamic, there is something called as a flow impingement. That means inside the blood vessel, the flow is jetting on that particular part. So that part is slowly getting tilled out, and which is responsible for the bleeding. And there are many papers been published about it. And it also not only has effect on the thinning of the wall, but also about the growth of the aneurysm. Like this paper, the predicting the growth of middle cerebral artery bifurcation aneurysm using difference in the bifurcation angle and inflow coefficient with the use of flow dynamics. And that brings us to this concept about basilar tip aneurysm. Now in the modern endovascular area, all these basilar tip aneurysm are being treated by web devices. There are special flow diverter devices which are called web device, and those are used in this. But computational flow dynamic can actually tell us whether in that particular case the web device will be useful or it will fail. Because if we assess these two cases here, the one on the top and one here, in the bottom case you can see there is direct jetting of the flow into the aneurysm, which is called as flow impingement. So this case has a flow impingement into the aneurysm. So in this case, if we use web, it won't work. Unlike the first case, the flow is getting diverted into different vessel and there is no jetting of the blood directly into the aneurysm. So this is the picture. If there is flow impingement directly into the aneurysm, and if we use web in that, the web will collapse, because even after you put a web, that flow pattern will be there. You're not disturbing to the flow pattern. That flow pattern will keep on hampering on the web device, and the web device will eventually collapse. So there are two options in the modern endovascular area. They say you either use two web devices simultaneously, so you create more metal area, or you use web device along with the coiling. So like these different cases, this first case, there's too much of flow impingement. Again, not suitable for the flow diverter, because flow diverters are not actually flow diverter, they are flow disruptors. So if we have too much of flow impingement into the aneurysm, those cases become not ideal for standalone flow diverter, but you should use coil along with the flow diverter or stunt assisted coiling. So now let's go to the second part of my presentation about the retrospective analysis of all the cases which I had done. A small introduction: the flow diverter and stunt assisted coiling are the endovascular intervention aimed at the reconstruction of the parent artery and occluding an aneurysm. So why I'm doing this study? So this is the way the endovascular treatment has evolved. Initially, we were using only coils. Then the coils were coming out of the aneurysm. If the aneurysm is wide neck, so we started using balloon assisted coiling. But even with that, the aneurysms were not getting thrombosed. So we came up with the new coils like penumbra coils and hydro coils and matrix coils, which are thrombogenic coils. If the coil is there, blood is supposed to clot, blood is supposed to get thrombosed. There are thrombogenic coils. And the next is stunt. So sometimes even balloon assisted coiling was not working. We needed something to support them, keep the coils inside the aneurysm. So we started using stent, and now we are in this era where we're doing flow diverter. And there are different types of flow diverter, pipeline flow diverter, web, different types of flow diverter available in the market. So which one is the best? Of course, as you go according to the evolution, the flow diverters are best. But in this subcontinent, finance, economy, lot of factors rather than are important when you take a decision, both in the government practice or in private practice. So when flow diverter is the standard, whether is there any role of stunt assisted coiling or just coil or just balloon assisted coiling, that's what I wanted to see. So that's the aim of the study. Skip this part. So this is all the data during the COVID era. So total number of patients were 50, flow diverter alone were 15. I like using coils along with the flow diverter 10 and stunt assisted coiling were 25. So I'll take you just slowly to few cases. So this was a patient from Kenya, a 58-year-old lady. She complained of a headache with a left-sided weakness, a left-sided gaze palsy actually, left sixth nerve palsy, left-sided blurred vision and double vision. You can see the left eyeball is having restriction of the movement towards the left. And this was the DSA report. Left wide neck cavernous segment ICA giant aneurysm. I'm sure if Professor Takizawa is there, he can do the bypass, but I'm not really well versed with the bypass, so I have to find the alternative. So in this case, we try to do a flow diverter placement. So this aneurysm is laterally directed. When it is laterally directed, it is going inside the cavernous segment. If it is medially directed, you can open the distal ring medially, so you are not in the cavernous sinus and you can clip it. But if it is laterally directed, then in the young neurosurgeon hand, it is very risky because you have to enter inside the cavernous segment and clip the aneurysm. So that's very risky. So just an exemplary case of flow diverter. There was no post-operative complication, went on well. Now this is what is this? 36-year-old male, systemic hypertension, known case of right MCA bifurcation, bleb aneurysm, which was already wrapping was done for that. And now this is what patient has, vertebro-basilar dissection. So what are the treatment options available for this? Surgically, not many things you can do, maybe a bypass, but what you can do is something called pajama flow diverter, like our two pajamas. So you have to put one flow diverter and one flow diverter perpendicular to that. And this is what a very nice reconstruction of both the vertebral and basilar could be achieved with this. Next case, 54-year-old female, diplopia since 1 year associated with the headache. And patient had, again, another laterally directed, laterally projected cavernous segment aneurysm. So we deployed the flow diverter, and this is the sign, very particular when you're doing the flow diverter on table to guess whether this flow diverter is working or not working. This is the sign. This is called a sun setting sign. When you are putting a flow diverter, you can see that aneurysmal, intra-aneurysmal blood flow is reduced and aneurysm is already started getting thrombosed, because that's what your whole aim is, to disrupt the flow inside the aneurysm. So this is the aneurysm. But as Professor Takizawa was saying, that in such cases, the the ICA is very tortuous, and not always you will be able to deploy or construct the ICA and place the flow diverter there. I'll show you one that case where I had a problem. Another case, 48-year-old lady on complaint of headache, had a giant ascending segment, giant aneurysm. And when we started putting the flow diverter, this is what the half of the aneurysm was like already getting thrombosed. So another case, 42-year-old male presented with the SH, and he was having a dolichoectatic dissecting aneurysm. So when there is a dissecting aneurysm, there's not much role of coils, because if your coils goes into the dissecting segment and perforate the vessel, then coils may come out. So only option is to use the flow diverters. So this is the case where we had managed with the flow diverter. Just in the interest of time, I'll skip these cases. And one last exemplary case of left cavernous segment IC aneurysm, where we had used a flow diverter. And while we were putting the flow diverter, as you can see, the distal tip had gone into the MCA. We'll park it in the M1, and slowly, there is a push and pull technique with which you have to slowly release the flow diverter. While you do that, you want the flow diverter to be nicely occluded over the wall. There should not be any space between the flow diverter and the wall, because that space becomes a potential space for either dissection or thrombus formation. So your intention is always to push more, and while pushing that, this is what happened. That flow diverter had kinked, and this is one of the very major complications. This you have to realize as soon as it is kinking, because you keep using the contrast in between. So then you realize, okay, it is getting kinked. So you stop pushing and pull it little bit, relax the flow diverter and deploy it again. So one case where we had problem and it was managed well. So that was flow diverter, cavernous segment aneurysm. Most of the time, standard of choice, standard of treatment is flow diverter. But as I said, we are in a subcontinent, we are a developing country. Not every patient is affordable. Sometimes no device is not available. There are many reasons. So we do have to use coils. Now you may wonder that in the cavernous segment, when the huge aneurysm is there, you put this coil mass, how it will do. But some cases we had done, and this was the result. 38-year-old male, headache with the left-sided weakness, left-sided blurred vision. And you can see he had a left-sided palsy, and this was the aneurysm. Just bang at the cavernous segment, little bit on the clinoid and supraclinoid, wide neck. The first coil, what we call a skeleton. So I deployed first coil that itself gave reduced flow inside the aneurysm, and this is how we had packed the aneurysm. There are softwares available when different company people come with you. They will give you this software. Whatever coil you use, along with that, they will give you information how much of percentage of coiling you have achieved inside the aneurysm. Minimum, you should achieve more than 25 to 30% to create a good thrombogenesis inside. So there you can see after the coiling, the first run, and this is the second run. As you can see, the aneurysm is completely coiled. And fortunately, this was the outcome. The patient, 6-nerve palsy, had completely recovered, and he was doing okay. Another case, 47-year-old lady, severe headache since 4 days, right ophthalmic segment IC aneurysm. Another classical case for flow diverter, but we had to use stent. This was done in long back, underwent stent assisted coiling. So this is what a big coil mass there. In today's era, you may not agree with this, but no, earlier when we didn't have the option, we used to adopt that. 60-year-old lady, headache, left ophthalmic segment aneurysm, and this is what stent assisted coiling. Actually, patient had bilateral mirror ophthalmic segment aneurysm, so which were coiled. And this brings me to this concept, as Professor Takizawa was saying, MCA bifurcation aneurysm. What can be done? MCA bifurcation aneurysm, either you can put web, because nowadays the webs are possible, but webs are very costly. So the another possibility is MCA bifurcation aneurysm. If you deploy a stent, as compared to this picture, if you see here, the aneurysm is bifurcation aneurysm. But if you deploy a stent, the bifurcation aneurysm actually becomes side wall aneurysm. So you have to see the anatomy, which segment is dominant, is it a superior or inferior segment, and choose in which segment you're going to deploy the stent. And you can get away MCA bifurcation aneurysm with the stent assisted coiling. So flow diverter and stent assisted coiling, peri-procedure complication, one complication in flow diverter, which I told you the flow diverter was getting kinked. Stent assisted coiling, we had 2 complications. Immediate post-operative complication, there's one case which I'll come to that. Clinical improvement, 6 months follow-up. There was one death. I'll show you the cause of that particular case. The rate of complete occlusion at 6 months follow-up was 10, and here was 8. Rate of recurrence was nil. So this is the basic concept of any aneurysm. When you treat with the flow diverter, when this is the flow pattern inside the aneurysm, you are trying to put the flow diverter in order to disrupt the flow of the blood from entering into the aneurysm, and aneurysm will eventually get thrombosed. But the problem is when you have this kind of system wherein the distal end is very small and the proximal end is very big, and you don't have that kind of customized flow diverter. Your flow diverter are always streamlined. They're not designed like that. And when there is a wide neck aneurysm, as I said, that you intentionally want to push the flow diverter because it should get nicely compacted and occluded over the wall. And while doing that, whenever you aggressively push, this is what happens, that you aggressively push too much and the flow diverter gets pushed inside the aneurysm. And this brings to this concept. This is what is happening. So we published this case, and we had put forward this particular hypothesis that when you push the flow diverter too much, there is something called as trans flow diverter migration of the thrombus. The thrombus which is there inside the aneurysm, which will get migrated here. Why? Because there is a zone of inertia. There is something called a zone of inertia. If you see a canal, if the canal is very narrow at the distal end and very wide at the proximal end, at the border there will be zone of inertia. The fluid in the center will be moving fast, fluid in the side will be moving less. And if you create that zone of inertia, there will be what is this concept, the trans flow diverter migration of the aneurysm. And this was the cause that we had one patient who eventually died on the 3rd day. When we had done a check DSA, the flow diverter was completely occluded. So our finding provides reliable evidence showing that the flow diverter may be a preferred treatment option for the intracranial aneurysm, especially large and giant unruptured aneurysm, but transvasal pushing of the side walls of flow diverter into the aneurysm should be avoided. Safe to use stent-assisted coiling in the wide neck aneurysm. And the last part of my slide, what do you do about recurrence of aneurysm post endovascular coiling or FD? So what are the causes and recurrence rate? Recurrence rates in the literature are 10 to 17%. The risk factor for recanalization are if the aneurysm is more than 10 mm, that's 1 centimeter. If the neck size is more than 4 mm or broad base, location, that is terminal type, are more prone to develop a recurrence as compared to the side wall. Ruptured aneurysm are more prone to recur. If you not use stent, then there can be possibility of coil migration, and incomplete embolization or incomplete coiling or loose coiling can be one of the reasons. This is one more concept which we had put, that ostium to the neck ratio. If this is the ICA, and there are 3 types of aneurysm. This is one aneurysm which is on the greater curvature, this aneurysm which is on the lesser curvature, this aneurysm which is on the greater curvature. So the aneurysm which is on the greater curvature is more prone to develop a recurrence or failure of flow diverter or stent assisted coiling. This I've already spoken. There's a classification given by Raymond Roy for the recurrence of the coil, that is type 1 means there is no recurrence, it is totally occluded. Type 2 means there is some remnant of the neck. Type 3 means the coil are very loose and there is some flow inside the aneurysm. And type 4 means the coils are pushed on one side. It's called coil compaction. Coils are pushed on one side, and that's why the aneurysm is growing. So the indication for surgery is if there is any present of remnants after the coiling, if there is a mass effect of the coiled aneurysm, recanalization and growth due to coil compaction. As you can see, this were the coils here, this were the coil getting compacted, coil compacted more, then aneurysm has gone, and migration of the coils like this. They can migrate inside the parent vessel or they can migrate outside. So the last slide, what are the surgical or techniques or challenges to manage this case? So of course, surgery is the first line of management, but the first surgical option is direct clipping or double clipping. But the challenges are narrow neck, compaction height more than 2 mm, and coils not protruding in the parent vessel. If the coils are not in the parent vessel, you can go directly clip it. The challenges are dissection of the aneurysm because there is too much of fibrosis, and coil removal is a challenge. Next option is wrapping. If you can just put a cotton or muslin, or sometimes we use Teflon to wrap the aneurysm in. Personally, I like muscle patch because I feel muscle patch creates more better fibrosis. Next option is clipping aneurysm with the coil extrusion. So you can put a temporary clip, remove the coils, and then reapply the clip on the neck again. Next option is trapping and bypass. So if the coils are protruded into the parent vessel and you cannot take it out, you have to trap it and do bypass. So thank you very much. Those were the cases which I had and the points which I wanted to mention. Thank you.
Thank you, Dr. Kim. It's a very wonderful presentation. I have a query. For such flow diverter or other coil issue, the device procurement is a big factor because it's a highly costly thing.
I cannot hear.
Regarding the device procurement, this flow diverter is a huge costly issue. Like socio-economic condition, your country and our country, we face difficulties regarding the cost issue to counsel the patient. But what is the status in your country? How do you manage such thing? Is it government subsidized, or your patient has to pay, or any insurance covered?
Yeah, so this is a good question he has asked, that in our subcontinent, it's sometimes not possible to use flow diverter because they are very costly. So what are the alternative options? So first of all, we have to know why they are costly. Because there is a monopoly. There are certain countries which are making these coils. If you see, the cost of production of these coils is not very much. But since there is a monopoly, they charge it very high and they sell it. So if we try to produce these coils in our own country, then the cost will come down. And that, our generation, the young neurosurgeon, have to partner with the technology, with the engineers, and somehow try to bring in that technology to your country and try to do it. One thing. Second thing, at the moment, it is not possible. So what we can do is, there are certain private funding companies, like in India, we have Bajaj Finance, we have Tata Finance. These funding companies will loan you that amount, and you can repay that amount later. So one is, you have to have insurance earlier. So with that insurance, you can take the treatment. If you don't have an insurance, you can go and ask the funding company that I need this particular device, please help me out. So they pay for you, and then you can pay them later. Like as if you're buying a car and prepaying the EMI of the car. So that can be done. Thank you.
Hello. Shochin, congratulations for your Shochin Tendulkar-like presentation. First thing, you have tell that your recurrence rate is 10 to 17%. How you have managed these recurrent cases? Secondly, you have told that coil itself produce mass effect which needs surgical intervention. How many cases you have to operate?
So, okay. For those 17 to 20% is not, it's not mine, it is the international data, because that was the third part of presentation. So the international data says that around 10 to 15% recurrence rate. Recurrence, it's not a recurrence rate, I'll say a failure rate. Either the coil is compacted, or the neck has grown, or there is a coil prolapse into the parent vessel, or outside, some form of insult has happened.
What is your experience in your series?
As I said, in flow diverter, I had one patient who died out of the 25 flow diverter which I had used. In case of shunt-assisted coiling, there are 2 cases which I had intraoperative complication. Apart from that, post-operatively, I didn't have any much. But when you do a 6 months follow-up scan, on the scan, flow diverter shows a good occlusion of the aneurysm as compared to shunt-assisted coiling.
Coil produce the
coil producing mass effect. See, some cases which we had done around 5-6 years ago when flow diverter was not very much available, even in Apollo, we had no choice but to use a lot of coils inside the cavernous segment aneurysm. One of the drawback of that is because of the mass effect, whatever neurological sign patient has, the 6-nerve palsy especially, because all those are laterally directed, the 6-nerve palsy will not recover.
Yes.
Okay.
So thank you. Any comment or query from the audience session? Audience, please, any question or query? Okay, then we can request our expert panel to comment, please.
We are good, thanks.
Okay, thank you.
So this is the end of this scientific session. Now I am requesting all the participants to be seated because there are two attractive sessions now. At first, I will declare the name of best questionnaire. During the conference, we distributed some card for writing some question. We got around 30 to 35 questions. Among them, our expert panel selected 5 persons as a best questionnaire. Now I am declaring the name of the best question. Dr. Mahmudul Hassan. I am requesting Professor Muhammad Shafiq Islam, Secretary of the Society of Neurosurgeons, and Abdul Aziz, Marketing Manager of Renata Limited, to come in the dais and deliver the prizes. Mr. Abdul Aziz and Professor Dr. Muhammad Shafiqul Islam, Dr. Muhammad Mahmudul Hassan, best questionnaire, one of the best questionnaire. And this presentation is sponsored by Renata Limited. Now I am requesting Dr. Muhammad Asadud Jaman to come in the dais. Dr. Muhammad Asadud Jaman. Topic was mechanical thrombectomy. The question was, is there any risk factor of distal embolization during mechanical thrombectomy? Which one was the better using suction device during removal of the clot or not, or any other suction device? This was the question. Our next winner, Dr. Muhammad Mahbub Hassan from BSMMU. Mahbub Hassan, BSMMU. His question was, how much lumen should remain patent for carotid artery stenting? What is the success or recurrence rate? Our next winner, Dr. Shubhra Bonik from NINS. Shubhra Bonik. His question was, what is the golden hour between onset of symptom and time of clipping, and what about the success rate? Next question, best questionnaire is Dr. Ayatul Amin. Dr. Ayatul Amin from NINS. His question is, what will be the longest period for applying temporary clip in case of aneurysm surgery of brain? Dr. Ayatul Amin. So this session was sponsored by Renata Limited. Shoaib bhai thaken. Now there is another attractive session, that is one raffle draw. This is also sponsored by Renata Limited. I am requesting other EC officials of Bangladesh Society of New Surgeons to come in the dais. Dr. Fazle Elahi Milad. Any Professor Washid sir, Professor Dr. Mohammad Joinul Islam sir, Joinul bhai, আসেন এই আগে আসেন 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 নিজেরটা নিজে তুলে নেন আসেন কয়টা হবে 10টা So attractive raffle draw will give 10 prizes. 10 prizes, all prizes are same, so there is no question of first and second, but there is will be serial for prizes. So first lucky one. নিয়ে নেন একটা উঠান নাম্বারটা বলুন
ডক্টর মোহাম্মদ রিয়াজ আহমেদ হাওলাদার
067 রিয়াজ এটা উঠে যাবে রিয়াজই উঠে যাবে
নেক্সট চাপলে উঠাবে চাপ
রিয়াজকে উঠাবে
for the next. Sorry,
Shahriar Islam Khan.
He's not there right now, I think. Oh, nai ekhon. Repeat হবে
এটা পৌঁছে দাও
আবারও আইতুল ইসলাম, you are lucky guy না
না না না এটা তো
আইতুল তো না
না না আলিফুল ইসলাম আলিফুল ইসলাম
আলী না
আলিফুল ইসলাম
না
ফোন নম্বরটা চেক করি লাস্টের 2 ডিজিট হচ্ছে 1919 0186 1254719 same guy নেক্সট হচ্ছে ডাক্তার ইসমাইল আজম জিকো
I am requesting Mohammad Sakaut Hussain, General Manager Sales, Renata Limited, to come in the dais.
ডাক্তার তানভীর হাসান মজুমদার এটা দেওয়া হয় না রেখে দেন দেওয়া হয়েছে
কি বলবো নাম স্যার না না পড়ে দাও কে এম তারিকুল ডক্টর কে এম তারিকুল ইসলাম লাকি ম্যান পয়েন্ট তুলে দিয়ে যাক তুলো তুমি লাকি উইনারটা উঠে নিয়েছো তুমি ঘোষণা করবে আর তুলে দিবে এই তুলো আমারটা তুললাম
না তোমার কি দুইটা নিবা? ওকে।
Kanis Fatema Ishrat Jahan.
হ্যাঁ, ইসরাত তো ছবি তিনটা ছাড়াও তিনটা।
এই তিনটা
allocate হয়ে গেছে।
একটা তুলে যাও।
এ তো বিদেশি মনে হচ্ছে না, করতে পারতেছি না। নামই করা যাচ্ছে না।
Hey, Tendin, Bhutan, that resident from Bhutan. Yeah, Dr. Tendin Wangdil Dorji. Probably he's from Bhutan. He's not there.
সুমাইয়া রহমান।
Dr. Sumaya Rahman.
স্যার ও তো লোক
ও আসুক রাইট
ওই তো ও দর্শন
স্যার
আরেকটা আছে না, একটা আছে এখানে বলে দেন লাস্ট ওয়ান।
আমাদের এটিএম দিয়ে আমাদের কয়জন আছে রে? এটিএম দিয়ে কয়জন আছে? সো এটিএম আসাদুল্লাহ।
তাহলে ডিনার কি 8টা? So this is our last prize. The thank I'm thank you very much Renata Limited for arranging such a attractive session. Now I am requesting all the participants to stay in the hotel lobby. We will serve our dinner just at 8 p.m. sharp at 8 p.m. So please you are remain in the hotel area. Okay. Thank you very much.
হ্যালো সাউন্ড নাই স্যার হ্যালো না আসেনি স্যার হ্যালো থ্যাংক ইউ স্যার আমাকে একটু হাতে পারে হ্যালো আসেনি ওরা কই হ্যালো নাই হ্যালো ওদের ডাক দে সাউন্ড সিস্টেমে কাউকে ডাক দে মাহমুদ Hello, an important announcement for tomorrow. The endovascular training instrument, Mentis and simulator will remain 1 p.m. tomorrow. So those are interested to train in endovascular neurosurgery, and just like today, they will get the opportunity tomorrow up to 1 p.m. Okay, thank you.